We are going to continue on with our chapter, starting with benign masses. And there's quite a few if you're looking at like this outline. There's multiple different benign cystic and solid masses that can occur. So not all breast masses are malignant, which is good. So we're gonna first start with what is our qualification for like a cyst. So a simple true cyst, which you're going to see quite a bit when you're doing breast ultrasounds, is epithelial lined, filled with that serous fluid that has acoustic enhancement. Usually occurs 30 to 50 years of age, can be single or multiple. They're asymptomatic, palpable. Some can be tender, oval, smooth, freely movable, so you can kind of move them around. On sonography, they have a thin margin, which is a huge thing. You know, we want a thin wall, we want acoustic enhancement, we don't want any internal echoes. Those are our three qualifications for a simple cyst. You can also have something in the breast called a fibrocystic change, which we'll talk about a little bit later. But those usually occur around 35 to 55 years of age. It's epithelial hyperplasia, stromal fibrosis, and cyst formations. So with these, this is like a hormonal thing that happens to some patients, where their breast gets full, they feel like it's really tender, they can feel a couple of masses, and when you're looking, you just see like quite a few cysts, small cysts, could be microcysts, but not really any huge nodule or anything, and usually that is like fibrocystic changes. So this is a simple cyst. So this is on mammogram on image A, and it shows a rounded circumscribed water density mass with a radiolucent halo, which is the arrow. On sonogram, it demonstrates a circumscribed, thin-walled anechoic mass with enhanced sound transmission and refractive edge shadowing. This is like a cyst like you would see in the ovary, any liver, any of the other things that we've talked about. So you're going to see that a lot. That's benign, and those three qualifications really show that. And the second picture is a multiple cyst, and this is more of like a fibrocystic changes within the breast. And this is like an extended field of view sonogram, and it's high resolution. So you can see that that's very detailed oriented and very sharp. But you can see all these little cysts down here. There's also sonographic table features of non-simple cyst when your cyst is not just easy with it doesn't have the three things. There's something else that is happening with it. It's either filled with internal echoes or complex. So they kind of put it in complicated cyst and complex cyst. So complicated cyst would be a thin-walled cyst, so still has thin walls, but has low-level internal echoes, like a fluid debris level and fat fluid level. So any kind of fluid level, which we'll look at in just a second. And an inflamed infected cyst, the difference there is it's going to have a thicker wall. So anytime something is inflamed, it has a thick wall, and there's going to be a lot of blood flow and excessive blood flow around the wall, confirmed by Doppler, and that's an inflamed. A complex cyst lesion that's suspicious is a thick walls, thick septations, an intracystic mass, and then a mixed solid cystic component. So here you're looking at complicated cysts. The first one is floating internal echoes. The second one is like more of a fluid debris level or fat fluid level. And the third is a fluid debris level. So that would be what we call a complicated cyst. You're going to also see a lot of this in the second picture here. like a cluster cyst, basically. It's a cyst cluster. And I think I saw something that looks similar to this more of the time than I did simple cyst or complex cyst. This is an infected cyst, and you can see this by the wall thickening. So if you can see the wall around here, almost looks like a gallbladder that's gone bad. So some treatment for a cyst would be an aspiration of a symptomatic cyst. So if it's giving the patient pain, they could, have it aspirated, or they might, if it's suspicious, they're going to do a vacuum assisted biopsy or a core biopsy. This is what we call galactocele. And this shows a unilocular cystic mass of mixed echogenicities due to the milky, fatty contents. So a galactocele is a milky cyst, because the breasts produce milks, and milky cyst caused by an obstruction of the lactophorus duct in a pregnant or lactating women. So a galactocele is going to be more in someone that is producing milk. So the sonographic features of this is oval, circumscribed, unilocular, or multilocular. You're going to see some fluid fat levels, but there's going to be an absence of blood flow and posterior acoustic enhancement. Those occur in pregnant or lactating moms. So you all might get a sebaceous cyst too, and those are going to be more on the skin layer here. And small skin appendage mass from obstructed sebaceous gland or hair follicle. And these are what these look like. They're often near the axilla or inferior medial margins. Sonographically, they're superficial, claw-like, which I was like, I don't really see the claw, but I guess sometimes they can look, well, as they're extending into the skin, they can look claw-like. Low medium echoes, no internal Doppler. They may require a standoff pad, or a lot of gel, because the focus of the ultrasound beam is too far for it. So since it's so close to the surface, they might need what is called a standoff pad to see it, or extra gel, so the ultrasound waves can pick it up. I'm sure all you guys have heard of what mastitis is before, but mastitis is like infection of the breast that most oftenly occurs during pregnancy or lactation. So it usually is caused by staph infection when an infection gets in when there's like an abrasion from nursing. And then the infection spreads from the nipple into the ducts and can cause so much pain. And the patient can get so sick. And it can swell your breast up. It could be red. You can have a fever. You just feel like total crap. Most often presents in pregnancy and lactation. There are some non-lactational forms. So you can get some forms when you're not pregnant if there's a ruptured cyst or enlarged duct, or from a post-surgical infection, like if a patient has like a breast reduction, or if you've just had periductal inflammation, because sometimes the body is weird and likes to do weird things like get inflamed for no reason. But without treatment, an abscess may develop. And we know by now, like with all of our studies, that abscess, whenever you get abscess, it's not good. And in the breast, definitely not good. So you're going to have, for sonographic findings, you'll have subareolar, which is below the nipple thickness, nodularity, sticky nipple discharge, nipple retraction, and you're going to see dilated ducts that show isochoic walls and internal echoes. So the sonographic features do vary with the stage and how far along you are in the inflammatory process. But the inflamed skin prompts the search of underlying skin infection or infected duct or fluid collection. Usually, they can go ahead and give antibiotics if you're not too far gone. But sometimes I had a friend that had it really bad and they had to do IV antibiotics for her, and she was really sick. So let's say the mastitis just continues to get worse, then, and it's not treated because the patient doesn't go, or just like, this must be because of nursing, or I must have a clogged duct, or all the things that you would make excuses for not going, because you're just so busy, you're tired with your baby. So if it does get out of hand, you can form an abscess, which is necrotic tissue and pus. And it's most of the time beneath the nipple because that's how the infection spreads. And by that time, the patient's going to have fever, pain, reddening, and thickening of skin. So sonographically, it again depends on the stage and distribution, or how far the inflammatory process has gone. But you're going to have a very swollen breast, reduced delineation of the Cooper ligaments, so you're not going to be able to see those as well. Dilated lymphatic channels because, the infection is going through the lymph nodes, and tissue necrosis. So if this occurs, you're going to have antibiotic treatment too. And the patients do recover from that, but it's pretty bad. Maunder disease is interesting. It's where you can get thrombophlebitis of the superficial veins of the chest wall and the breast. So if a patient has a hypercoagulable state or some kind of blood clotting disorder, if they're dehydrated or they have some sort of cancer, they could get potentially small thrombosis in the superficial veins. So what they're going to feel like and look like are tender cord-like superficial masses. When you're in a long view, you're going to see like just a vein, and when you turn into short axis, you're going to see a circle, because that's how the vein works. And you're going to see the internal echoes of the vein, which is the clotting part. You can also get a hematoma, and I can imagine that this would hurt very bad. Now, why would you have a breast injury? A lot of people think, like, how could I hurt my breast like that? But think about if you're in a car accident and the seatbelt is on your breast and can cause a hematoma. So it's a blood-filled mass. So you're going to have bruising and skin thickening, appearance variable based on amount of liquefaction and clotting, blood present, and color Doppler confirms absence of blood flow. They would not want to do probably a mammography if a patient comes in like with this because of the pain. So that you might scan a hematoma, and what you're going to see is just an echogenic mass with internal echoes, basically. And then, you put that together with what has occurred or the breast injury, and it makes pretty good sense that that's probably why she has a breast mass. A seroma is accumulation of serum that can collect within a surgical cavity or a biopsy site. A seroma from a lumpectomy site can help reduce the deformity by allowing breast tissue to reshape as the fluid collection regresses. So this one right here, that on the left, that is a hematoma. This is a split screen because it was so big they had to do 2 screens. It's 8 centimeters, which is pretty big for a breast. It's fluid-filled echogenic mass that resulted from a seatbelt injury. A small area of hypercoagulated clotted blood is present, if you see on the left split screen. And skin thickening accompanies the area of bruising. So the second screen is from a pseudoaneurysm from a post-biopsy. So this image, the color flow Doppler reveals blood flow within the neck of the post-biopsy pseudoaneurysm, which is pretty interesting. Fat necrosis is uncommon. Inflammatory and ischemic process that is a consequence of blunt breast trauma. Again, the seatbelt injury, surgery, reduction, radiotherapy, or inflammation. So basically what happens is trauma can disrupt the blood supply, causing hemorrhage and liquefaction of the focal area of the breast fat, resulting in necrosis and some foreign body reaction. Sonographically, fat necrosis also has a range of different appearances. Initially, it can be increased echogenicity, and then can become more hypoechoic as it develops. This one on the right, of course, is hypoechoic. You can also get scarring, like a little mass from scarring, connective tissue proliferation. So this kind of, it shadows down like a malignant mass. But when you put some pressure, the shadowing will go away when you're doing a scar scan. So the image is of a post-surgical scar. So with these solid breast masses, 80% of the biopsies are benign, which is great. Solid masses are assigned risk depending on what they look like. And benign, displaced rather than invade, are well circumscribed, and gentle macrolobulation, malignant, are invasive and indistinct. So that's always going to be your thing with a benign mass. They're prettier, and with a malignant mass, they're ugly. They're just ugly, and they look mean, and they're not well circumscribed. You can't really even tell the borders. They're shadowing. They're just terrible. But some of the solid mass benign features that we want to know are that they can be oval. There's gentle lobulations if there's lobulation present, but there's really, they're gentle. They're not jagged. They're wider than tall. That's a huge thing. So that means that it measures greater in horizontal dimensions than AP. And they have a thin echogenic pseudocapsule, so it's going to be circumscribed. The most common solid breast mass is a fibroadenoma, and I think those are going to be beyond just seeing a cyst. You're going to see these the most. And it does have some benign features if we were just talking about. It's wider than tall. It's well circumscribed, and it's the same echogenicity throughout. So they're the most common benign solid tumors between 15 and 35 years of age. There can be single or multiple, and they may affect both breasts, but they're slow growing and most measure less than 3 centimeters. They're not really tender. They're firm and rubbery, and they can kind of move around. They're homogeneous, which is huge, and Doppler can sometimes show vascularity, which is fine, but that's definitely a benign mass. Adenomas are a little bit less common, and they can occur like when you're lactating, but they can get pretty big. So this image is of a secretory adenoma. So it's from a lactating woman. Notice the enlarging breast mass. Sonography displays a large lobulated circumscribed mass with isoechoic and hyperechoic internal echoes. The mass diminished in size after cessation of breastfeeding. Phyllodes tumor is interesting too. They're rare fibroepithelial neoplasms with a leaf-like growth pattern. The tumor resembles fibroadenoma, but has more stromal cellularity and contains narrow cyst-like clefts. The median age of the presentation for these are around 44th decade, which is later than a fibroadenoma. A hamartoma are they're unusual benign masses made up of varying amounts of normal and dysplastic fibrous tissue. They're generally unilateral and they can get bigger than 3 centimeters, so they're larger, but they're usually painless. They're oval, mixed echo pattern, and compressed surrounding tissue. A lipoma is with adipose tissue. They're slow growing, but they can get pretty big, up to 10 centimeters. So they're palpable, painless, smooth, soft, and compressible. So our neck, look how big that one is as well. It's past 3 centimeters. So this is a hamartoma. Sonogram shows a mass within the mammary zone that displays a mixture of echogenistes. So this is a good image of a lipoma with transducer pressure, how it compresses. So the first image is without compression and the second image is with. So when they're talking about that, that's what they're talking about. And this is a hyperechoic lipoma. So when I see like a echogenic mass, it reminds me it's probably like more of a fatty mass because they tend to show up more hyperechoic. You can also have intraductal papillomas, intracystic papillomas, and papillomatosis. Common occurs during late reproductive years, focal overgrowth of duct epithelia. So these masses or cysts are going to be in the ducts. I always thought scanning ducts was hard. But you could have small papillary growths in the small ducts. They're asymptomatic, but they may cause some bloody or watery nipple discharge, localized dilatation of solitary duct, color flow, and fibrovascular stalk. So I'm going to talk about this A here because I think it's interesting because I always was having trouble with scanning below the nipple where a lot of these masses are. They're subareolar where the ducts meet because the nipple shadows quite a bit. So there is this technique called a rolled nipple technique. And what happens is the transducer is in a radial plane along the axis of the duct to be examined. The non-scanning hand is placed on the opposite side of the breast to provide counter pressure, and the transducer is angled by applying pressure to the peripheral edge of the transducer. The maneuver brings the subareolar duct into scan plane more parallel to the transducer, so it's not shadowing as much, because that's where a lot of little masses like to hide, especially if there's bloody discharge. You would definitely want to look here. Sliding the transducer toward the nipple follows the duct. So if you decide to be a breast sonographer or you do a lot of breast in the hospital, this might be a good exam or a good technique to try to do that. And I'm sure once you get to your clinical sites, if you're doing breast a lot, they'll show you all their different tricks because there are a lot. The second one is intracystic papillomas. So the sonogram documented a solid papillary lesion projecting into a cyst. That's what this hypoechoic area is. The cyst is caused by obstruction of the duct by indwelling mass. So which is the characteristic of a complex cyst? Is it thin-walled? Probably not. Thick septations, no internal echoes, or hyperemia. What do you guys think? Thick septations. Anything thick is more complex. Which pathology is likely when a woman presents with a fever, skin reddening, and pussy discharge? If you said C, abscess, you're correct. Which feature is likely to be benign? Wider than tall, spiculation, acoustic shadowing, or duct extension? Wider than tall, you're right. And which huge axillary solid mass appears oval, gently lobulated, and hypoechoic with cystic spaces? Huge axillary solid mass. Is it a phylode? All right. Next time, we'll talk about malignant. Have a good night.